Good morning. My name is Bijan. I'm a radiologist from California. I work at SMG and UC Deep, and I was invited to Russian National Congress of Radiology in 2016, and I want to share with you MRI application in ovarian cancer imaging. I would like to tell you that I have no definite financial disclosure, and I want to thank Professor Kokov, Professor Ternovov, Professor Sarova, and Dr. Pavlova for inviting me to the Congress of Radiology this year. Let me start with some basics about ovarian cancer imaging in general. Most of the ovarian cancers are small and are detected incidentally. Some of them are really big and they can cause symptoms, and then they present with a large pelvic or even abdominal mass as the initial presentation. Ultrasound is a very powerful modality for characterization of ovarian lesion, but its sensitivity is a little bit guarded. It is less than 50%, although it has a good specificity. Doing endovaginal taking and Doppler certainly enhances its ability to detect and also for characterization of these kind of lesions. We presented a poster discussing type 1 and type 2 ovarian cancers in ultrasound, using ultrasound at RSNA last year, and this is available to you online if you want to go and download it. Let's talk a little bit about CT scan. CT scan also is a good modality in detecting large and characterizing the large ovarian masses or lesions. It can do characterization of dermoid and teratomas, of course, but when it comes to detection of the small lesions, it is very difficult. Overall accuracy in 70s, 80s, and 90s percent. It is very good modality for the restaging, especially if patient is postoperative and the CA125 is increasing. So in those patients who are postoperative, symptomatic, or they have biomarkers like CA125, then doing the CT scan is actually very useful for detection of recurrence, relapse. And sensitivity of peritoneal deposits, if the peritoneal deposits are big, larger than 1 centimeter or 2 centimeter, CT is as good as MRI. So you don't need to do MRI for those. For the lesions more than 1 centimeter, CT is very good. CT is superior to the MR for evaluation of the mesenteric disease, and also for those cancers that have calcification. Now, calcification is something that on the MR, not everybody is able to pick them up. Of course, we can use on the gradient echo, for example, sometimes we can find calcification, and those with trained eyes and some level of expertise, they should be able to detect calcification on the MR, but generally it is very difficult to look at the lesion with calcification by MR, and CT is definitely has an advantage. So for mesenteric disease and for those ovarian lesion with calcification, CT is superior to MRI. Now, PET-CT is the new modality that we have in our armamentarium, and for most of the time we use glucose, that's FDG, F18 FDG, and this is a glycolysis map of the body. We assume that the malignant lesions, they have high metabolism, and benign lesions, they have low metabolism. So we call them FDG avid, and the others we just say low FDG uptake. Sensitivity of the PET-CT using FDG is in the range of 50-60%, but specificity is a little bit higher, or in the range of 70 to 80%. Now, there are 3 sets of problems with PET-CT. Number one, there are a large group of cancers that we call them borderline tumors or low-grade tumors. These are usually hypometabolic. So if they're hypometabolic, we will not be able to pick them up on the PET scan. Then also lesions can be very small. If they're too small, it is below the resolution of the PET to be able to detect them. The third problem that we have for the PET scan is some of the benign lesions, they show high metabolic activity. Now imagine infection, inflammation, hydrosalpinx, pyrosalpinx, because they produce inflammation also. Some pedunculated fibroids and endometriosis, they have high metabolic activities, so they are positive on the PET scan, therefore they can actually pose as false positives. So not every benign lesion is hypometabolic. The lesion that I listed for you, they are hypermetabolic, therefore you will have difficulty differentiating them by only using PET CT from the malignant lesions. But PET CT definitely has a role, and the role is in staging and ruling out recurrence. The only problem is immediately postoperatively you cannot use the PET CT. Why? Because immediately in the postoperative phase, in the first month or 2 or 3, you have inflammation at the site of the surgery, especially in the cases that you do retroperitoneal nodal resection. You're going to cause a lot of inflammation, healing going on in the retroperitoneum. So just because of the inflammation, you will have high metabolic activity. It gives you a false positive for your PET scan. So that is one thing. The second thing is when you put the incision can cause some inflammation and makes the picture very complicated, very complex and complicated for interpretation. So we prefer not to do the PET scan in the first 3 months or in the first 6 months. But if you see any abnormal focus of activity after 6 months, then those are probably metastases, and we have to kind of treat them accordingly. Okay, now let's talk about MRI. MRI is very powerful modality in detection and characterization and for local regional staging of ovarian cancer. So these three are important: detection, characterization, and local regional staging. The protocol that I usually like to use, I have a T2, can be single shot spinnacle T2. And I usually have a T1. It's in phase, out of phase. I do 2 different types of fat suppression. You can use either frequency coded fat suppression, or you can do in and out of phase kind of fat suppression. In and out of phase T1 is a very cheap sequence. It takes about 30 seconds, 40 seconds, 1 minute, depends on your magnet system that you have, and you can kind of shrink it into even shorter interval. This need to be done before your contrast. Now, this is different than your T2. Your T2, in theory, can be done after your contrast. With the one caveat that I need to mention, that contrast affects T1, but it also affects T2. This is not something that everybody pay attention to. Contrast also affects your T2 images. Now, it is not clinically that significant to do the T2 after your contrast. If you have to, you can do it. In most of the protocols that I have, I try to minimize the duration of the imaging to under 30 minutes, preferably in the 20 minutes time. For the contrast, we can use in phase out of, we can use 0, 1, 3, 5 minutes, and if you need to, do the delayed one, and delayed can be done at about 10 minutes. Now, many people, they don't want to do a delayed, but I personally prefer doing the delayed because I think there's a lot of information we can still catch there. That's number one. Number two, by the time that you do 10 minutes, you have urine in the ureters, and you can actually evaluate both ureters, because as you know, obstruction of the ureters can upstage your staging. So, having that in mind, let me just walk you through some quick sequences of how to write the protocol. So if this is your timeline, okay. So first you start with your localizer. That takes about, let's say, 1 minute. So the first minute we're going to spend doing localizer. Then after that, do your in phase, out of phase. This is in phase, out of phase, T1. That takes another minute or so. Then at this time, do your DWI if you need to. This is the DWI time. After that, give your contrast. This is 0 minutes. That is 1 minute. That is 3 minutes. And if you want, you can do a 5 minutes as well. Now, if you want to do 10 minutes here, you have this interval that you are waiting. During this time, you can do your T2. When you do the delayed, usually I do them in the axial or the best plane, but on the delayed I usually do it in all different directions: axial, coronal, and sagittal. T2 I prefer to do it axial. It depends on the tumor, sometimes coronal, sometimes sagittal. So this is a protocol that you can, in theory, able to do it in less than 20 minutes, less than half an hour. Very important to have short sequences, because if you keep the patient in the magnet for 45 minutes, patient will move, and when patient moves, you're going to have artifact. So it's not really helping you, and it is very difficult for the patient to tolerate 45 minutes in the magnet. So my goal is shrinking my protocols into under 30 minutes, preferably under 20 minutes. And one of the things that you can do is do your T2 here between your 5 and 10 minute scan. Let's talk about this, see how good is MRI. For detection, it's very sensitive, 80 to 90, even high 90% sensitivity, but and specificity is also very good, is in high 90s. But when it comes to characterization, the numbers are a little bit more guarded. MRI is very, very good for characterization of fat, blood, and water. I mean, these are very, very easy for MR to see. When it comes to fibers and solid structures, it is kind of okay, it's good, but it is not adequate still for differentiating benign versus malignant. There are a lot of findings that can be suggestive one way or another, but when it comes to, it is not still adequate per current literature to differentiate between benign and malignants. Let's talk a little bit about DWI. DWI alone, when you compare it with MRI alone, and when you compare it with the DWI incorporated to the MR protocol, clearly MRI with DWI is better than DWI alone and MR alone. DWI is kind of functional imaging, one of the functional parameters that we use for imaging, like PET scan, for example. MR, the rest of the MR is more anatomical imaging. So MRI enhanced by DWI is actually functional with incorporated anatomical imaging at the same time. Think of this, that DWI MR is like PET CT, just a little bit better maybe. DWI is a very fast sequence. It's very cost efficient to use it. It is non-invasive, clearly doesn't have the radiation, and there's no need for giving contrast. Remember that a patient with renal failure, we have difficulty giving IV contrast of MRI, but these patients can easily undergo DWI imaging with anatomical imaging using MR, and we just do not do the contrast part of it. DWI has a very high negative predictive value. This is very important. High negative predictive value means that you can rule out malignancy. Now, positive predictive value is not that good. It is very limited positive predictive value, but negative predictive value is something that we can market on. So if you do the MRI and you do not, and the DWI you do not see you don't see any lesion with MRI, and DWI is also negative, this automatically has a very high negative predictive value. You can kind of count it as negative study for malignancy. So this is very, very important. But when it shows something, the positive predictive value is limited, as I said. Fundamentals of DWI, I don't want to get into too much technical nitty-gritty of that, but it actually, what it does, it checks the motion of the water in its microscopic level. It is microenvironment. So if you have too many interfaces in a tissue, let's say it's very, very highly cellular structure, the protons, the water molecule, the protons cannot move through this tissue in its microenvironment. Therefore, their diffusion is restricted. Now, then the name that we kind of use when we call it when we look at them these free motions, it gives the phase incoherence, which we call it signal loss, and when you have a restriction, you have their in-phase coherence, and we call them signal gain. So every DWI should have a B0. This is one of the parameters. You have the B0, which is intensity of the MPG pulse that we apply. So we definitely do a one low B and one high B. Low B is somewhere, we usually do it at 0, but you can also do it at any under 100, and the unit of B is second per millimeter cube, millimeter square. And the high B values of anything over 500, we can do 700, 800, 1000, 1500 and 2000 are also other options. So always in the minimum, for the research purpose, you can kind of do multiple, you can do 4 or 5 just to optimize your magnet, but at some point you have to decide what you want to do. My recommendation is do the 0 if you want to do an intermediate like 300, 400, and do another like in the range of 1000. 800 or 1000, both of them are good. Just to show you some graphics here, if your tissue is highly cellular, this is from the literature, if it's a highly cellular, the water motion, the water molecules cannot have a restricted motion, they cannot move fast enough. In the intercellular space, they just hit the membrane or other structures inside of the cell. Within the cell there are many organelles, and motion is very restricted. And outside of this, in the extracellular space also, the water cannot move fast enough. Now, when you look at the lesions that are hypocellular, like most of the benign lesions are, for example, are hypocellular, the water outside can actually move very freely, and even not too much water inside of the cell to have restriction. Therefore, lesions with high cellularity, they have restriction motion. Now, another thing I want to talk to you about, there are 2 other entities. One of them is necrosis or swelling or early response to therapy that ADC DWI is very good for. When this is the normal tissue, this is the tumor tissue. When you give some sort of treatment, these cells, they swell up, they get inflamed. Which maybe I shouldn't use called inflammation, but the membrane permeability goes up and the water goes in, and these cells are swelling up and get into rupture actually. And when they get bigger and bigger, so they have more fluid inside, so the motion is actually be easier in them. So that is one of the things that you can detect the early response to therapy by using DWI. And then when you have cell necrosis, these cells get ruptured, and now they take much less space in the microenvironment. Therefore, that also contributes. These are the application of specific application of DWI for evaluation of the peritoneum and omentum. As you know, evaluation of the omentum and peritoneum is very difficult by CT and almost impossible by ultrasound, unless you're talking about the nodules in the anterior abdominal wall. But DWI can help you detect these. There are difficult areas in the abdomen, for example, over the surface of the liver, the subdiaphragmatic or suprahepatic space. That's some place that actually gynecologists, when they open the abdomen, they go and actually touch that area. Even they get biopsies from there if they feel any abnormality. So that is one of the areas that actually we can detect by MRI by DWI much easier. Evaluation of the mesentery, the surface of the bowel, is very difficult to evaluate by any other modality. So these are the advantages. So these are the specific areas that DWI shows distinct advantage compared to other cross-sectional imaging modalities, including ultrasound, CT, and even PET. With PET, they're competing neck to neck. So the DWI and FDG, actually, they look very much alike. So that's kind of exception. ADC is not an imaging modality, really. ADC is a mathematical drive from different B-value images. When you do DWI, diffusion-weighted imaging, that is a true image. But ADC is not a true image. ADC is mathematically driven information, that the image that we kind of produce is not acquired. We produce by mathematical calculation using 2 different B. We are kind of predicting where this curve is going. So in general, the cancers like this, those show restricted diffusion, they have high DWI and low ADC, and then those have no restriction, they have low DWI and high ADC. They usually go reverse. There are exceptions to that I may touch upon later on. Malignant lesions in general, they cause restriction of diffusion. The reason for that is, number one, because they're hypercellular. There are a lot of cells, not too much extracellular space. Number two, the cellular permeability is restricted. And number three, the extracellular space shows a lot of tortuosity, and this tortuosity basically makes the water molecule difficult to move. So these are the three reasons that why a malignant lesion they show restriction. There are a few exceptions that some of the malignant lesions, they don't cause these restrictions, and those are the tumors which are heterogeneous, like they have areas of necrosis, for example. There are tumors that are not very hypercellular, they're hypocellular, low cellularity, that can be one reason. And the lesions, tumors with high cystic components. These are exception to the rule. They show low diffusion restriction in compared to generally all the malignant lesions. We said they have high diffusion restriction. For these three reasons, you can have some malignancies, they have low, and there are exceptions to the rule. But most of the benign lesions, they show low diffusion restriction. Basically, water can move very, very easily through them, and there are two exceptions to that. These are two exceptions that you have to kind of pay attention to. One of them is teratoma, the other one is endometrioma. Teratoma, it contains a carotenoid content. Because of this carotenoid content, it has high restriction. Endometrioma is a different story. Endometrioma has blood degradation product inside, and that's what the reason of the high restriction. So keep these two in mind. Two benign lesions, in general, benign lesions, they don't cause diffusion restriction. Two of them they do, teratoma and endometrioma. So know these two exceptions. But this is not one of the really downsides of MRI. We can diagnose both of them with a very good accuracy using other MRI parameters. So we don't trust our DWI for this. You have to look at your other sequences. For teratoma, it's very easy. You do fat suppression, and if you have the signal loss, you know it has a fat content, therefore it is teratoma dermoid, like dermoid. Then we have to check for the malignant component of teratoma, if there is any. And endometrioma is very easy. Endometrioma, because of blood degradation product, it has iron. And this iron causes T2 shading. On the T2, you can actually see that. And sometimes on T1, you see white signal. And white signal basically tells you this as a high protein or blood product. As you know, subacute blood is white on T1. Acute blood is black, and very chronic blood can also be black. But subacute blood, most of the time happening in endometrioma, they are white on T1, and on T2 they're a little bit dark, and we call it T2 shading. So using other techniques of the MRI, you can actually make the diagnosis of these two. Do not trust your DWI. So this was an important caveat that I kind of wanted to mention to you. So when you read the MRI, you have to kind of pay attention to. DWI is specific application is for tissue characterization, for staging, for evaluation of the response to therapy, and for detection of the recurrence evaluation, or we call it restaging. So these are the four major indications that we use DWI for, and it has, of course, for different type of cell line and different tumors, it has different sensitivity and specificities. I want to quote this Japanese article that they talked about the DWI in diagnosis of gynecological disease, and this is a very nice algorithm that they proposed. And this is how they looked at it. They look at it. First, they start with looking at the T1 fat suppression and T2 images before they jump into the DWI. This is another Japanese literature that I want to quote. The malignant lesion in general, they have lower ADC values compared to the benign lesions. Of course, an area going to be an overlap area, but that's how it is. If you have a low DWI and high ADC, probably it is benign lesion. Okay, now let's go and now that we talked about all the theoretical part of the lecture, let's talk a little bit more clinical. Let's just go over a few of these ovarian cancers. Epithelial tumor of the ovary, there are 60% of all of the tumor of the ovary are epithelial. 85% of all the malignancies are epithelial. 2/3 of them, fortunately, they are benign, but 1/3 are still malignant. There's a small group of them, less than 5%, they are borderline lesions, which mean that they have low malignant potential. Two major components of them are serous and mucinous. They also remember that endometriosis can be associated with two types of tumors. So whenever you see an endometriosis, don't just call it endometriosis and continue. Whenever you see endometriosis, specifically check for two types of cancers: clear cell cancer and endometrioid carcinoma. There are many cases of that. I had like one less than a month ago that there was endometriosis associated with endometrioid carcinoma. So these are the two tumors that you have to kind of, I'm going to emphasize on that. You have to pay attention to endometrioid carcinoma and clear cell carcinoma. Now let's talk a little bit about these two tumors. Serous tumors are usually unilocular. They're like one big component or one or two or three big components. Sometimes you see papillary projections into the cyst. They are associated with calcification, and very often they are bilateral. Now, contrary to that, mucinous tumors, they are usually multilocular. Each locule have different intensity, different content. There can be blood product or can be protein content. But each component, they have different intensities on, especially on T1 images, also sometimes in T2. It is in contrast to serous tumors. In serous tumors, all of them, they almost have same, and all of them, they have like water intensity signal. Papillary projections are rare. Calcifications are rare, and they're not usually bilateral. So that's how actually you can kind of use as a general guideline differentiating the serous from the mucinous tumors. These are the four criteria that you can kind of pay attention to. These are one of from our cases. As you see here, this is a big cystic component here, that you see in T2 images, and it doesn't show any unusual enhancement, with the exception of this little area that is a projection into the cystic component. As I said, it is either one big or a few big cysts. That's how it looks like, and as you see here, this lesion is not causing any restriction in the mural nodule, and then cystic the cystic component shows the T2 shine through on DWI images. Take a look at this one. This is another example of serous cancer. As you see here, it has a one very large cystic component, and it has this solid component which is projecting into the cystic component. And this image that you see here is actually a compiled image. It is combination of your T2 superimposed with DWI with a color map on it. So this way, this image, when you use the T2 with DWI using this kind of color scheme, it looks like PET CT, but you have to know this is not that. So as you see here, this shows high DWI and low ADC. It shows restriction of the diffusion. Now, in contrast to what I showed you before, take a look at this case. This case has multiple different compartments. These compartments, many of them are small. They have different intensity. For example, the brightness here is different than the brightness here is different than brightness here. Therefore, different components, you look at it, most likely you're looking at the mucinous cancer. Yeah, this one didn't cause any restriction. What are the signs of benignity? In general, if the size is less than 4 centimeter, if this is unilocular, if the septum and the wall is less than 2 millimeters or 3 millimeters, and if they don't show any diffusion restriction in the solid component, most likely you're looking at a benign entity. Now, in contrast, if the size is bigger than 4 cm, if it is multiloculated, if it has large soft tissue component, if the wall or septal thickness is more than 3 millimeters, if you see any secondary sign like ascites, metastasis, and lymph nodes, these are all malignant features. And in DWI, you see restriction of the of diffusion in the solid component, and it's very important. I'm saying in the solid component, don't check the cystic component. Cystic component, you know it is water. You have to check the solid component, DWI ADC, in the solid component of these cystic/solid lesions that we are talking about. Take a look at take a look at this this study. This is a case of a ovarian adenocarcinoma. As you see, this has a big cystic component with a large solid component as well. And this solid component shows a high signal on DWI and dark signal on ADC. So this has a definitely malignant feature. As you see here, this is the this heterogeneous appearance of the tumor on the histology. Take a look at this one. This is an example of endometrioma with endometrioid carcinoma. As you see, there's a cystic component and multiple solid components. And when you want to check the DWI, you check the DWI in the solid component of it. So, for example, here you see the solid component, which shows high signal on DWI and low signal on ADC. And the central part of that is necrosed, this black area, which you can kind of match it between these different series, and you see here is white. So that actually tells you that there's a central necrosis associated with that. Tumor can have different parts. Not all the tumors are homogeneous, and there are for many different reasons. For example, a tumor can have necrosis, can have many different things, including tumor can be polyclonal, meaning that there are different cell lines. Tumor is not a stable cell. They don't have a stable cell line. You're going to have mutations along the way, just because the nucleus is not very stable. So in one tumor, you're going to have the high grade, intermediate, and low grade different components. And actually that is important when you look at the ADC, DWI, and also it is important when you give a treatment, because not all the different cell lines in single tumor are going to respond same to radiation or chemotherapy. So the most aggressive component of any tumor, and this is just a general thing I want to share with you. The most aggressive part of the tumor responds to radiation. The most aggressive part of the tumor responds to chemotherapy. And the least aggressive part of the tumor, they don't respond really well to radiation or chemotherapy. So you are treating the most aggressive, but later on, this less aggressive tumor, the well differentiated or the well differentiated portion of the tumor can actually grow and take over. That happens, for example, very often in lymphoma, and also can happen in ovarian malignancies if they don't take them out completely. Let's take a look at this one. This is another case for clear cell carcinoma. The last two cases I showed you, this one, which is an endometrioid carcinoma, and then this one, which is the clear cell carcinoma. These are the two tumors that are associated with endometrial cancer. So pay attention whenever you have are associated with endometrioma. So whenever you have endometrioma, you have to pay attention specifically to these two type of tumors. Okay. Now let's take a look at this one. As you see here, it has large cystic component as well as a solid component. And the solid component is a part that you have to check your DWI ADC in. And as you see here, it caused diffusion restriction in the solid component. Therefore, most likely it is malignant. And this is the case of ovarian clear cell carcinoma. Now, this is a nice example of a peritoneal implant. This peritoneal implant is really big. And DWI here shows clearly the high signal, which is low on ADC. And just think about it. If this tumor was very, very small, it would be very difficult for a reader on CT or on MRI to detect it. But just because it shows high DWI, on DWI image, finding this tumor is very, very easy. So DWI increases your sensitivity for evaluation of the peritoneal implants and mesenteric tumors and suprahepatic or subdiaphragmatic recess. These are difficult areas in the between leaves of mesentery is difficult area to evaluate, and this actually is a huge help for that. Let's talk a little bit about the endometrioma. These are the two entities, benign entities, that actually they can look malignant on DWI, can cause diffusion restriction, and one of them is endometrioma. Endometrioma is an old terminology. The new terminology for that is external endometriosis. Basically, it is ectopically located endometrioma and endometrium. When the endometrium and the basalis portion of endometrium is inserted or heterotopically located within the myometrium, we call it adenomyosis, or another name for that is internal endometriosis. When these basalis cells of the endometrium is heterotopically located outside of the uterus within the peritoneal cavity, for example in the posterior cul-de-sac, we call them external endometriosis. It's the same pathology, just the name is different. So internal endometriosis is called adenomyosis and external endometriosis is called endometrioma. Now, they have blood degradation product. That's why they show this T2 shading. They can cause a lot of inflammation. And if they rupture, they can actually cause a lot of problem in the abdomen. Those are lesions that the surgeon, they go in, and when they are cutting them out, they'll make sure that they don't spill the cystic component of that into the abdomen, because as I said, can cause adhesion. Sometimes endometrioma can cause adhesion and cause tethering of the bowel. Sometimes it can cause adhesion of the uterus to the rectum or sigmoid colon. It can cause all sorts of pelvic pain. And they can be actually very, very subtle. 50% of them they show restriction, 50% of them they don't show restriction. So this is one of the tumors, one of the lesions, let's call it lesions in the pelvis, that can give you DWI restriction. Okay, so this is an example of that. As you see here, this is white on T1, is black on T2 because of the T2 shading, and the restriction here, they did not show any kind of restriction. Therefore, this is an example of that. But 50% of them, they show restriction. Teratomas are the lesions with 3 germ cell layers. They can be the mature one are benign. The immature one are malignant, and some of them they can actually be mono or bidermal. Can have 1 or 2, but most of them they have all 3 components. The mature teratoma, mature cystic teratoma, the other includes dermoid. Dermoid is a common one that we see very often, and within this you see fat, you see debris, you see calcification, and even you can see hair. Now this is a little bit different. I'm going to call it fat, but by fat I don't really mean fat. By fat I really mean oil. There's a big difference between fat that you see in lipoma versus fat you see in dermoid. The fat you see in lipoma are fat within lipocyte, so that's intracellular fat, right? But the fat that you see in dermoid cyst, it's not intracellular fat. It is in the cystic component in the acellular part of the lesion. So that's extracellular fat, the one. So I would like actually to call them oil rather than call them fat. We have 2 different type of fat suppression. You can have macroscopic fat suppression, which is frequency-coded fat suppression, or you can have microscopic fat suppression, which is in-phase, out-of-phase T1 sequences. Teratomas, as I talked to you about before, they can show restriction. They can actually look malignant. The cystic component can look malignant, and this is because of the carotenoid content of the lesion. So they can actually have low ADC values like malignant tumors, but you are using other techniques, as I said, with fat suppression and those and even on the CT, you can kind of see other features of dermoid, so you can actually make a diagnosis based on the MRI or CT without using your DWI. Example. Let me show you an example. Example of that. You're using the in-phase out-of-phase. You can see fat suppression of the macroscopic fat. On the gadolinium, you see there's the wall can enhance a little bit, but the minimal enhancement of the wall is expected in dermoid, by the way. And the DWI here shows restriction, and we talked about it. The cause of the restriction is carotenoid content of it. The very last part, I want to talk to you about fibrous tumors of the ovary. The three fibrous tumors that you need to know is fibroma, fibrotecoma, and Brenner tumors. Okay, these are three types of tumors that you kind of need to know. Fibroma and fibrotecoma, can be associated with Meigs syndrome, and Meigs syndrome is when you have right-sided pleural effusion, small effusion, ascites, and the benign solid tumors of the ovary. So whenever you see one of these fibrotecomas or fibromas, watch out for others, for ascites, for right pleural effusion, to see if you are catching a Meigs syndrome. They have one feature. They are low on T2 and they're low on DWI. This is what we call it T2 blackout effect. So if you see a tumor is dark on T2 and it has low DWI, it is T2 blackout. Differential diagnosis narrows to 3, to fibroma, fibrotecoma, or Brenner tumor, and all of them are like benign. So you don't even need to be worried about. So T2 blackout effect means benign tumor in general. Based on the clinical scenario, gynecologists may go for elective resection of it. Let me show you an example of each. These are from our series. By the way, I have to give credit to one of our former residents, Dr. Lisa Chu, for putting together all this material for a publication that we have been working on. Hopefully it comes out soon, and I really need to thank her for all of her hard work on this project. This is another case that we had. This is the T2 blackout. On T2 it is black, and on DWI it is black. Therefore, by looking at it, you know this is probably a benign tumor. This case has ascites. I don't know if this case has right-sided pleural effusion or not, because if the case has a right-sided pleural effusion, then probably you are looking at the Meigs syndrome. Take a look at this case. This is a similar kind of a lesion as prior case. On T2 it is black, and on DWI it is black, and it turned out to be another solid tumor. This was Brenner tumors. By the way, this is for the residents. This is T2. How do I know it's T2? Because you can see the zonal anatomy of the uterus. If you can see the zonal anatomy of the uterus, you're looking at the T2. Same thing true for the male. If you see a zonal anatomy of the prostate, you're looking at the T2. There are exceptions happen to the rule. That's why in the very first slide I told you that the DWI is not very good in completely differentiating malignant versus benign. It can do some tissue characterization, but differentiation malignant versus benign can be problematic. This is a lesion which is a very poorly differentiated ovarian cancer, and it shows no appreciable enhancement on the gadolinium, and did not show any restriction on the DWI images. This but turned out to be a malignant tumor. This is just a pitfall. So do not trust too much on that. You have to know there's an overlap between the benign and malignant ADCs. And the reason for that is because most of them are because of the tumor heterogeneity, because it has it may have necrosis, it can have low cystic area, low cellular area, or it can have a large cystic component. So this is why some of the malignant lesions, they can actually look benign, and we already talked about it these benign lesions that can look malignant. So these are two entities that you need to kind of be familiar with when we talk about them. Susceptibility artifact is another thing. It gets worse as your magnet is more is stronger. So the 1.5 is shows more susceptibility artifact compared to 0.3 or 0.5, and of course 3 Tesla shows more susceptibility compared to 1.5 Tesla. As a summary, if you want to take a review this table together, this basically shows you different benign and different malignant lesions with different T1 and T2 DWI ADC characteristics. So I want to you pay attention to this area. If a lesion is dark on DWI and this is dark on T2 and this, and they may actually show a little enhancement, most likely you are looking at fibroma, fibrotecoma, or brain tumor, and these are all these are those that show T2 blackout. Thank you very much for your attention. If there is any question, you can always contact me at drbijanbijan@gmail.com. Thank you.